So with that, let's transition to prescribing cholinesterase inhibitors. There are four in the market, three basically in use. Donepezil is the most commonly used. The trade name is Aricept, but it's available generically. It's FDA approved for mild, moderate, and severe Alzheimer's disease in doses from 5, 10 to 23 milligrams daily. And one would start at 5 milligrams daily for 4 weeks and then try to titrate up to 10 milligrams. We will occasionally start at 2.5 milligrams if for a person, say, who's a little more frail, just to assess tolerability. We might do that for a week or two and then go to 5 milligrams. The 23 milligram dose can be a little more effective in some people, but it does have more side effects. So we don't use that dose very often, but it has been shown to offer a little more efficacy, but at the cost of higher side effect risk. Galantamine extended release, trade name is Razidine. This is approved for mild to moderate Alzheimer's disease. It's dosed orally once daily, titrating from 8 milligrams to 16 milligrams to 24 milligrams, increasing every 4 weeks. Then there's rivastigmine, which is available both orally and transdermally. This is also approved for mild to moderate Alzheimer's disease, also approved for Parkinson's disease dementia. The oral preparation is 1.5 milligrams twice daily for 4 weeks, and then 3 milligrams twice daily for 4 weeks, then 4.5 milligrams twice daily for 4 weeks, and then 6 milligrams twice daily orally. So that is a very slow titration schedule because of the high likelihood of this medication causing nausea. So the patch bypasses the gut, less risk of nausea, still can cause some of the other side effects of cholinesterase inhibitors, such as bradycardia and urinary urgency. Anorexia, nausea, diarrhea, bradycardia with potential for syncope, and urinary frequency are the most common limiting side effects of these medications. What you can expect from these medications is about a 10 to 20% of people showing some good response, noticeable improvement, and 50% showing at least stabilization of cognitive decline over 10 to 12 months. There have been placebo-controlled trials going out longer than a year, showing that these drugs probably do offer benefit for some long-term outcomes, even though patients may still be declining. So these drugs may improve cognition and neuropsychiatric symptoms. They do have psychotropic effects, especially in people with Lewy body disease and Parkinson's disease dementia. And so Alzheimer's disease, diffuse Lewy body disease, and Parkinson's disease dementia are certainly patients in whom a trial of these medications is justified. Some people advocate their use with small vessel vascular disease, but I would not use it in people with frontal temporal dementia, traumatic brain injuries. And I would also be very cautious about using it in people over 85. The risk-benefit ratio just likely isn't worth it. Plus, these patients often have mixed pathologies: Alzheimer's disease, Lewy body disease, small vessel vascular disease, and other proteinopathies more recently described. And so, possibly if a person really has Lewy body disease, you might consider doing it, but using a trial of one of these medications, but generally use them with extreme caution. A lot of questions about when to taper these drugs. We don't have good evidence base to go by, so it's a clinical decision. I generally maintain people on medications for 2, 3, 4 years, depending on how they're doing. Once they start to have profound impairment, less interaction, less mobility, I would taper it. I wouldn't discontinue the medication unless there is a medical reason to do so, such as bradycardia. One should really follow patients on these medications at least at 3 to 6 month intervals, just to assess tolerability and provide all the counseling and medical monitoring that these patients need. Memantine is an NMDA receptor antagonist. It basically restores cell function for cells that are being damaged by the disease. It allows them to sort of come back online, so to speak, and respond to neurotransmitters. So you have a cholinesterase inhibitor increasing acetylcholine levels. Memantine increases the cell's ability to respond to the acetylcholine as well as other receptors. Indicated for moderate to severe dementia. The mild dementia studies did not show benefit. You titrate the immediate release 5 milligrams daily, then for a week, then 5 milligrams twice daily, then 5 and 10 for a week, and then 10 milligrams twice daily. So you get up to 10 milligrams twice daily after 4 weeks. The extended release form starts at 7 milligrams once daily, and you titrate to 14, 21, and 28 at weekly intervals. 28 is the maintenance dose. You may see improvements in clarity of thinking and ADL function. These drugs are not necessarily memory drugs. They do help frontal executive function. They do help memory to a degree. They just help people think more clearly. That applies to cholinesterase inhibitors too. People may not necessarily have better memory, but they certainly have better focus, attention, and processing. Memantine works as monotherapy, but it's better with a cholinesterase inhibitor. And watch for dizziness and headache from memantine. There are several studies showing alpha tocopherol providing some benefit. There's at least 3 positive studies. Has a modest benefit through its antioxidant function. Free radical oxidation is one of the mechanisms in neurodegeneration from neuroinflammation that occurs in people with Alzheimer's disease. It's worth considering if people want everything done for them. The doses that have been studied to be effective are at 2,000 international units a day. That's a lot. There's some bleeding risk associated with that dose, although in the studies it was very well tolerated. It takes at least 800 a day, international units a day, to get significant brain levels. So that's why these doses have to be high. I want to end by discussing treating neuropsychiatric symptoms. This is, of course, a lecture in itself. The symptoms should be defined in terms of when they occurred, what triggers them, and what, if any, interventions ameliorate them. Talking to people, exercise, a midday nap, a midday snack, or lunch, in other words, or a mid-afternoon snack is what I meant to say. It's helpful to define the nature and severity of symptoms with a rating scale. We recommend a brief scale called the Neuropsychiatric Inventory, the quick version, the Q, NPIQ. One also has to assess for physical distress. Pain is a frequent cause of agitation, dysphoria, hunger, constipation, another cause of agitation and restlessness. Boredom is another cause, or overstimulation, just too much happening in the environment with a person who just can't process complex stimuli very well. Also, interpersonal interactions may trigger a person's overreaction. People with brain diseases both underreact as well as overreact. They have stimulus-bound behaviors, so they tend to react very impulsively to environmental stimuli. So this may take a little detective work, and observing people in their environment, say in a nursing home, can be very helpful. You should employ a full range of environmental, social, food, sleep, rest, music, and activity-focused interventions. We're sending you a handout by the American Geriatric Society that lays out a procedure for this very nicely. You might consider an SSRI or SNRI antidepressant for people with anxiety or dysphoric irritability, very, very common in Alzheimer's disease. And then, although antipsychotic drugs have a black box warning and are high-risk medications, They're frequently necessary, at least for short term, when there's intense mood dysregulation or psychotic symptoms. They're the most effective things we have, despite modest efficacy. They're still the most effective medications we have for paranoia and psychotic symptoms or severe mood disorders. Agitation is a tricky area because, again, it could be lots of things, including pain and constipation or urinary retention or dysphoric irritability. So agitation itself may not be an appropriate indication, but sometimes if it's severe and the family and the person is just not manageable with non-pharmacologic interventions, using antipsychotic medications might be reasonable. Use a low dose, monitor them closely, explain the risk and benefits to the family, and attempt to reduce or discontinue after 12 weeks, unless there's a history of chronic recurrent symptoms or a chronic psychiatric disorder, such as bipolar disorder, that might be contributing to the agitation or paranoia. And underlying psychiatric disorders are common and may justify ongoing use. But you must assess the patient at frequent intervals for lethargy, oversedation, or neurologic side effects of these medications. It's the lethargy and oversedation that increases risk the most, especially risk of aspiration. You might also consider melatonin, trazodone, or low-dose quetiapine for sleep disturbance associated with dementias. Sleep disturbance is pretty common in people with Alzheimer's disease, and we don't have good placebo-controlled data for trazodone or quetiapine. We do for melatonin, and most of the studies have been negative, but there's a little bit of a signal, and some people do respond well to melatonin. But in clinical use, trazodone and low-dose quetiapine are community standards, even though the empiric evidence isn't what we would want it to be. But certainly worth trying if the family is highly distressed. So sleep disorders are both a risk factor and symptoms of dementia, and of course they do have a big impact on caregivers. Alzheimer's disease is perhaps accelerated. The underlying pathology can be accelerated by inadequate sleep because beta amyloid protein production shuts down during sleep, and it's slowly cleared from the brain during sleep. So the shorter the sleep period, the shorter the period in which beta amyloid can be cleared from the brain. Also, insomnia and fragmentation of sleep is a symptom. It's both a cause or a contributor and a symptom of the disease, as the basic mechanisms for sleep-wake cycle break down. More sleep during the day, less sleep at night. There's also a loss of rapid eye movement sleep and more daytime sleep, as I mentioned, and less and frequent nighttime awakening. Sleep fragmentation. People tend to catnap with sleep off and on during the day and the night. With vascular dementia, there's nighttime breathing disorders are very common, as well as daytime sleepiness. And with Lewy body dementia and Parkinson's disease dementia, there's not only frequent daytime sleepiness, but also REM behavior at night in a large proportion of people. REM behavior disorder is loss of REM-associated atonia, loss of muscle tone, through decreased locus coeruleus inhibition of corticospinal motor flow, very closely associated with the alpha-synucleinopathies such as Parkinson's disease and Lewy body disease. And the sleep-related behaviors may predate the other symptoms, both the motor symptoms and the cognitive symptoms, by several years. This generally requires polysomnography to confirm the diagnosis, and especially to rule out obstructive sleep apnea, which can also cause agitated behaviors. So questions to ask about this when with a patient whom you suspect might have Lewy body or Parkinson's disease is whether the bed partner, if there is one, is getting punched or kicked during the night. Sometimes people literally jump out of bed, but usually this is just flailing of arms and legs and a lot of vocalizations during REM sleep. If you watch your dog or your cat sleep, you might see some muscle twitching, some myoclonus during REM sleep. And in fact, a locus coeruleus lesion in other mammals also produces this REM behavior disorder. The treatment is with low-dose clonazepam, very low dose. You have to rule out obstructive sleep apnea, of course, because clonazepam can make that worse. Fortunately, high-dose melatonin sometimes works too. High doses meaning like 8 to 12 milligrams a night. This is a copy of the Neuropsychiatric Inventory. It's in the public domain. You can Google it. You can download it. It runs through 12 different neuropsychiatric symptoms. And when you're treating these symptoms, it's best to have a little bit of a quantifiable baseline to go by, and to guide to structure your interview with the family member, and also to reevaluate once you're treating them to make sure the numbers are coming down. And there you have it. I hope this was helpful to you, and look forward to more discussion. Thank you.